Joining us, we will now come to order for this Congressional Progressive Caucus shadow hearing entitled Patients Over Profits, Lowering Healthcare Costs for All Americans. Thank you all for participating in this hearing as policy changes have drastically shifted the healthcare landscape in this country. In my district within Arizona and across America, healthcare is becoming more expensive and difficult to access. My constituents, from healthcare professionals to patients, have expressed deep concern due to shifts in healthcare coverage. They have made it clear that we are facing a massive crisis in healthcare affordability, especially in light of the so-called Big Beautiful Bill Act. Medicare and Medicaid need protections and reinforcement now more than ever. Insurance premiums are rising, and millions of Americans have been stripped of their health care, with the expectation for millions more to lose Medicare and Medicaid as well. In the midst of unmitigated inflation, the American public is asked to make impossible economic trade-offs. Like the housing crisis, the cost of health care today is the result of policy choices, both historic and recent. Because health care was not so affordable for the American public, even before the big ugly bill was passed. We know why this is. Our healthcare system prioritizes corporations invested in profiting from Americans at their most vulnerable, when they are suffering from illness or injury. The price of prescription medication is underregulated, and corporate greed keeps the cost of hospital and clinic visits skyrocketing. Medical debt plagues our country, and Americans deserve better. Medicare and Medicaid create a healthy America. Stifling our healthcare programs has only made the need for Medicare for all more apparent. Healthcare is a human right. This is foundational and self-explanatory. Everyone deserves to be healthy. No one should suffer when we have the tools, resources, and capabilities to heal. And yet, we have sold off our healthcare to the highest bidder. Progressives are ready to tackle that issue with innovative policy and bold reforms. We have the legislation, we have the vision, and the energy to see it through. With Medicare for All, we can provide every American with access to medically necessary health care. The health of our nation cannot continue to be at the whims of corporations. We need to pass medical debt forgiveness, regulate prescription drug pricing, and invest in preventative care. Medical debt affects more than 40% of American adults. Anyone could experience illness or an accident that could drive them bankrupt. We could all need life-saving care at some point in our lives, and it should not cost our life savings. In the same vein, prescription drugs are unnecessarily expensive and costly because of corporate price gouging. Pharmaceutical companies know that these drugs save lives, and they intentionally profit off of people who depend on them to survive. And often, accidents or illnesses could be prevented if the right resources were properly invested in. Studies repeatedly demonstrate that investing in preventative care cuts costs for everyone. This reduces the economic burden on hospitals and taxpayers and is a proactive approach that has lasting long-term benefits for entire populations as well as individuals and corporations. We can invest in preventative care creatively and in more ways than one. Awareness and programming create opportunities for the public to prevent themselves from becoming ill in the first place. As a global leader in public health, America should set the tone on affordable health care and demonstrate cross-sectional approaches toward keeping our entire country as healthy as possible. Unfortunately, we are not showing that leadership. Case study after case study of countries from every continent demonstrate that implementing these programs comes with a host of benefits. Washington has instead chosen to punish Americans economically for falling ill and needing treatment in favor of corporate lobbyists. And this lowering cost task force is here to disrupt that pattern, instead displaying our commitment to the public by working for their health interests rather than against them. Today, we will hear from experts, advocates, and people on the front lines of this crisis about how we can create a healthier America. Their voices will help guide the agenda we're building and the legislation we will fight for in Congress. Because at the end of the day, the cost of health care is a function of a broken system, and we have the tools and the foresight to fix it. That is the future we are here to fight for. Thank you. I'm very much looking forward to today's discussion, and I will now turn it over to our co-host for this hearing, co-lead of the Medicare for All Act, Congresswoman Debbie Dingell.
Thank you, Chair. Sari, and for all the work that you are doing on lowering the cost task force. And it's such an important issue right now. Thank you for you organize this hearing. And thank you to the witnesses for being here today to share both your personal experiences, but your invaluable expertise as well. You know, people are really struggling. And if anybody's out there, if they're talking to just everyday people, you know how hard it is. You're all hearing dozens of stories from people who can't afford their health care anymore and are forced to go without certain necessities to compensate for rising costs. You hear it when you're in the grocery store, filling my car with gas this weekend, and this summer is for many young children with SNAP benefits cut. People are worried about young people just having access to food and being able to get a healthy meal. 1 year ago this week, the Trump administration signed their big, and I'm sorry, I try to behave, but I call it the big shitty bill, into law. I use a lot of other words, but I just promise to behave, which enacted drastic cuts to Medicaid, jeopardizing access to essential care for millions, worsening health outcomes, increased financial strain on the providers, and increasing the rates of disease, death, and uncompensated care. These impacts are disproportionately felt by the people that are the most vulnerable in our communities. Disabled people, seniors who rely on home and community-based services, which are the Medicaid-funded essential supports that help older people and people with disabilities with day-to-day activities such as bathing, dressing, managing medication, and participating in employment. You know, I was at Kroger Sunday morning. I always go to Kroger Sunday mornings, and people come and talk to me, and a mother came up to me, and she's a single mother, and she has a child with asthma, and she said to me, I can't afford the inhaler anymore for my child. Can you help me? And I will. But I can't. There's so many children out there that need somebody to care and help, and we can't do it one-on-one basis. We need programs that are not going to have a mother coming up to you that way, or a senior, her husband's dying of Alzheimer's, and said to me in the last couple of weeks, what's going to happen to me? I don't have the money when he dies. Who's going to take care of me? That should not be the story of the United States of America. This administration has doubled down on attacks on Medicaid-funded services like home and community-based care, claiming that the increased demand, including behavioral health services and other integral services for people with disabilities, or the growth in the number of direct care workers, is evidence of fraud, waste, and abuse. You know what the waste is? Long-term institutions, nursing homes, are more expensive than people having access to home and community-based care. Growth in Medicaid spending reflects the need of a rapidly growing population that requires care, and decades of progress to ensure people can live, age, and work with dignity in their own homes and in the communities that they've lived in, which is what most people most often prefer, rather than that costly institutional setting. Home care is less costly, resulting in savings for both the government, individuals, and families. HCBS programs provide the majority of funding for direct care workers, 37% of whom also rely on Medicaid for their own health coverage. 3 in 10, many of these caregivers, when they get sick, can't afford to go to a doctor. They don't have any benefits. 3 in 10 child care workers rely on Medicaid for health coverage. And at least 13% of family caregivers whose unpaid care contributed to more than $1 trillion to the economy depend on Medicaid for coverage. Cuts to Medicaid funding and unfairly targeting home and community-based care providers in the name of fraud, waste, and abuse will put care even farther out of reach for those who rely on it, for the caregivers and their families. Without this federal investment, states are left to fill the gap, like federal cuts, and are trying to proactively make changes to their budgets to make up for the decrease in federal support. And unfortunately, because Medicaid cuts funding, makes funding HCBS optional, that's the program that gets cut. It's one of the first to go. And people are really hurting. And even before these cuts, there's a tremendous amount of unmet need. So I'm really grateful to our witnesses and for being here and putting the human face on these stories, and I yield back.
Thank you so much, Congresswoman Dingell. Now we will move to our witness testimony. Our first witness is Topher Spiro, Senior Fellow at the Center for American Progress, where he oversees the Health Policy Department. With more than 20 years of experience in government and public policy, Spiro served in federal government, most recently as Associate Director for Health Programs at the White House Office of Management and Budget, otherwise known as OMB. As the Chief Health Finance Official of the federal government, he oversaw all healthcare spending, including more than $90 billion for the Department of Health and Human Services and tens of billions in COVID-19 funding. Before serving in the Biden administration, Spiro's advocacy at American Progress was widely credited as helping to save the Affordable Care Act from repeal. Thank you so much for your service, Mr. Spiro.
Thank you. Distinguished members of Congress, thank you for holding this hearing, since the congressional majority appears not to care about affordability. We are now at a breaking point when it comes to healthcare costs. For the first time ever, as measured by Gallup, fewer than half of Americans can afford healthcare. Because workers' total compensation includes wages and health benefits, rising costs reduce wage growth and increase unemployment. In other words, not only do rising costs force working families to ration, they also drive income inequality. The cause is clear: extreme concentration of healthcare corporations that extract obscene amounts of wealth by inflating medical prices and premiums. Hospital costs account for nearly 40% of private health insurance spending and are the main driver of cost growth. 94% of hospital markets are highly concentrated as defined by the Federal Trade Commission. The result? Since 2000, hospital prices have grown faster than prices for virtually everything else: prescription drugs, college tuition, childcare, housing, and food. The totality of evidence amassed from multiple studies over decades is clear. Large hospitals use market power to charge monopolistic prices, resulting in excess margins, higher premiums, higher deductibles, and higher out-of-pocket costs. Meanwhile, health insurance corporations are rigging the system. They gobble up doctors' offices, PBMs, and pharmacies. Those subsidiaries then inflate their prices. The parent insurer counts this as medical spending, then claims justification to inflate premiums, and both the parent insurer and its subsidiaries reap the profits. And they don't mind higher hospital prices because they can book that as medical spending and increase premiums and profits. Even worse, the practice of prior authorization has become a blanket barrier to care to boost profits. According to a recent systematic review, prior authorization is associated with worsening disease, preventable hospitalizations, longer hospital stays, and increased mortality. It is time to end this form of health discrimination. Insurance companies should not be in the business of making medical decisions. They should be covering the claims of people who are sick, not profiting from denials of care. In April, the Center for American Progress proposed a Patient's Bill of Rights to provide immediate relief on premiums, deductibles, and insurance denials. First, we propose to cap extreme hospital prices at no more than 3 times what Medicare pays. Rural and community hospitals would be exempt. Plans would be required to use the savings to cut average deductibles in half. Second, we would require insurance companies to rebate windfall profits to consumers, and they could not get around this requirement by using their subsidiaries to inflate prices. Third, as a general rule, premium increases should not exceed increases in the actual cost of care. This is common sense. If insurance companies can't justify bigger increases, they must modify them. And fourth, replace prior authorization by insurance bureaucrats with independent clinical review. Only the most costly, overused services should be subject to review, but by independent clinicians with a strict 48-hour deadline using evidence-based clinical guidelines. This agenda is focused on immediate relief alongside broader systemic reforms such as Medicare for All. Sending a bill to President Trump's desk next year will demonstrate your priorities and focus while Trump is focused on wasting $72 billion on a deeply unpopular war. Thank you, and I'm happy to answer your questions.
Thank you. Very powerful comments. Our next witness is Lisa Brown, the Executive Vice President of SEIU 1199. Our 1199 SEIU is the fastest growing healthcare union in the country, representing more than 450,000 healthcare workers across the country. The Maryland and D.C. division, which Vice President Brown leads, represents more than 10,000 healthcare workers. Ms. Brown, I love working with SEIU on caregiving because you're the voice for so many that don't have it. Thank you for being here today, and we look forward to your testimony.
Thank you, Chair Ansari and Co-Chair Dingell and other members of the Congressional Progressive Caucus for allowing me to speak to you today. My name is Lisa Brown. I'm the Executive Vice President of Maryland, D.C. Division, the fastest growing, everything that you just said. Actually, most of my speech has already been said today. And so what I would prefer to do is bring the voice of the members that I represent into the space. I represent nurses, professionals, service workers, the dietary, housekeeping. I represent nursing home workers. I represent clinic workers. And we are trying to represent home care workers who in the state of Maryland and D.C. have no voice. And it is unregulated. Anyone can open a home care agency. We have workers who have no health care because they can't afford it. They go to work and take care of patients every day, but they cannot afford health care for themselves. And these workers are dedicated workers. Nobody works in a nursing home because it's fun, because it is not fun. It is very labor-intensive work. It is heavy lifting. It is caring for people when they are at their weakest. It is doing all activities of daily living for people who could be your parents or your family. And so the feeling is there. And then you can't take your child to a doctor, or you end up having to use the emergency room for your health care provider. And I don't know if any of you have ever been in a hospital in Maryland, but emergency room wait times are the highest in the nation, right here in Maryland. And so we all know that it's corporate greed. We all know in nursing homes, the owners have multiple shell corporations to hide their profits. And then they're able to pull money out and put it directly in their bank accounts. We know this. We all know that CVS owns Aetna, who owns PBM, who owns clinics, who It is a scheme, and they are taking all of the wealth and do not want to give people, healthcare workers, a living wage. We know the living wage in the Maryland, D.C. region is $36 an hour. No service workers are making $36 an hour. They fight us tooth and nail to get people to $20 an hour. We are fighting right now to maintain health care costs, the premiums for workers in a clinic. The health care premium for a family is $11,000 a year. The nurse practitioner who can afford to pay that is fighting that we stop it for the service workers. That's what healthcare workers are being asked to do now. We have to fight, and we will fight. You know, 1199 SEIU, we are going to fight. But we need real help. This is not a Trump problem. Trump might exacerbate it, but he didn't create it, and we are all suffering from it. And so we are here to fight with you, to do whatever we have to do to make sure that we put health back in health care and take profit out, Medicare for all. I'm with you on that fight. Thank you.
Thank you so much, Lisa. Incredibly powerful testimony. We so appreciate you being here today. Our next witness is Robert Weissman, co-president of Public Citizen and a staunch public interest advocate and activist, as well as an expert on corporate and government accountability. His work and expertise span the effect of money on politics, economic and regulatory policy, corporate crime and wrongdoing, trade and globalization, financial reform, prescription drug pricing, and access to the courts. He worked as director of the corporate accountability organization Essential Action from 1995 to 2009, and from 1989 to 2009, he was editor of the Multinational Monitor, a magazine that tracked multinational corporations. He helped make HIV drugs available to the developing world. The list goes on and on. Thank you so much, Mr. Weissman. I will hand it over to you.
Thank you very much, and thanks for the opportunity to be here today. I'm going to talk about the drug pricing aspect of this story. Big Pharma's monopolistic price gouging is at record levels and completely out of control. There may be no issue that is more deeply and broadly felt. 4 out of 10 Americans ration the drugs that they need because they cannot afford them. The good news is there may be no price issue that is easier solved than drug pricing. It has nothing to do with labor costs or technology, input costs, geopolitical problems. It is entirely a function of government policy controlled by Big Pharma itself. So the solutions are at hand. I wanted to say something about the problems and then get to the solution part of the equation. The problem is indeed severe. The price of the median drug has risen from just over $2,000 per year in 2008 to more than $200,000 this year. So more than 100 times increase over the last 2 decades. Big Pharma is making out very well. The top 20 companies have made $400 billion in profits over the last 3 years. The CEOs are making out as well. They've taken home more than $300 million in collective pay every year. What makes this all even worse is if we understand how the government contributes and underlies the profitability of the industry. The U.S. government spends about $50 billion a year on pharmaceutical R&D. That's a great thing. Unfortunately, Big Pharma captures the benefits of that and gives us nothing back in return in terms of cost control. Why is Big Pharma able to charge so much? Because we grant them patents and other monopolies that give them the ability to charge whatever they want. We do that as the government, and we don't impose any controls on them. The U.S. government, through Medicare, is the world's single largest buyer of medicines. But until the adoption of the Inflation Reduction Act, because of Big Pharma's influence and probably the most corrupt deal in recent political history, Medicare was forbidden from even negotiating any prices for Medicare. So that's where we are. Out of control pricing because of government inaction and action. We grant them the monopolies that they benefit from. The good news is we've taken the first tiny step that shows us the way forward to deal with this. The Inflation Reduction Act did authorize Medicare to begin negotiating prices, and it's had an important effect. Modest compared to the scale of the problem, but an important effect. And it shows us the way forward, which is to build on that model to deal with the monopoly problem altogether. So 4 components of what we should do. First, Medicare negotiation should apply to all medicines, not just a limited set of them. Second, the Medicare negotiated price should start on day 1 that the product is introduced on the market, not delayed for 7, 9, 11, or 13 years. Third, the price has to be extended to the private market so that those who are not on Medicare get the same low price that Medicare is able to negotiate based on its negotiating power. And last, we should deal with the problem of too large out-of-pocket copays and drive that down below the $2,000 cap, ideally to 0, because there's no reason for anyone to pay for medicines that they need. No one is taking medicines as a luxury item. They're taking them because they need it. No one should have to ration them or be imposed upon. You're already sick. It's bad enough. You shouldn't have to pay more for it. So the solutions are at hand. The only challenge is whether we're going to muster the political will to take action. This is one of those issues, like so much of what the Congressional Progressive Caucus focuses on, that although only part of the Congress is willing to take on corporate power, all Americans want to see action. The polling is 80 to 90%, depending on what question you ask. Americans want aggressive action to bring down drug prices, and the more aggressive, the higher the poll numbers. They want expanded Medicare negotiation. They want it now. It's time to deliver it. Thank you so much.
Thank you so much, Mr. Weissman. That was very specific and extremely helpful. Thank you so much. Our 4th witness today is Nicole Jorwick, Chief Program Officer at Caring Across Generations. Ms. Jorwick is an experienced policy professional who has worked on disability and aging policy and supporting the direct care workforce. Before joining Care Across Generations, Ms. Jorwick was Senior Director of Policy at the ARC. Ms. Jorwick, thank you so much for being here today. We are very much looking forward to your testimony.
Thank you so much for having me, Chairwoman Ansari, Congresswoman Dingell, and members of the caucus. It's an honor to be here to testify. My name is Nicole Jorwick, and I'm the Chief Program Officer at Caring Across. We bring together family caregivers, care workers, seniors, and people with disabilities to push to make care accessible, affordable, and equitable for everyone who needs it. I am also a family caregiver. My brother Chris is 36. He has autism and relies on Medicaid home and community-based services in Illinois. And I'm one of the supports for my 3 grandparents who are all in their 90s who beg me every time I see them to fix this problem. I'm here because what is happening right now is not an abstract. It is happening to real families, millions of us. There are 130 million family caregivers in this country, to be exact, when you also count parents. And every day, 10,000 people are turning 65. More than 1 in 4 Americans have a disability. Every single person will one day need care or give care. And yet the costs of that care are crushing families who are already at their economic breaking point. This includes direct care workers who are more likely to rely on the same programs, Medicaid and SNAP, that H.R. 1 historically cut. Family caregivers, direct care workers, seniors, and people with disabilities face significant struggle with employment, finances, and well-being. Caregivers are more likely to be uninsured and less likely to have employer-sponsored health coverage than the national average. Also, Medicaid covers 13% of family caregivers for their own health care needs, underscoring how central Medicaid and the ACA are to people who give and receive care. And there isn't a way for families to make up for the lost coverage. Family caregivers already lose $470,000 over their lifetime in wages and retirement savings because of the care they're providing. The unpaid work of caregivers provides over $1.1 trillion to the economy as they fill in the gaps to the system. Caregivers are spending an average of 26% of their income on caregiving costs. And Medicaid, not Medicare, is how America actually pays for long-term care for the 8.4 million seniors and people with disabilities currently covered by the program. Yet because of caps to services, waits already existed before the H.R. 1 cuts came in of over more than 600,000 people. Health insurance doesn't cover long-term care, and private long-term care insurance is quite simply a market failure. Unaffordable, limited in scope, and customers more likely to be denied than covered. Private equity, after already gutting the nursing home industry, is now moving aggressively into home care, extracting profit through staffing and wage cuts. The private market has failed, and its greed has left a mark. Families have no choice but to grapple with astronomical costs of care. A full-time home health aide costs on average $68,000 a year. Round-the-clock care for someone with dementia or ALS can cost more than $288,000 annually. Medicare does not cover this, even though we have polling that shows that 93% of people believe that it should, and many believe it already does. Private long-term care insurance covers less than 4% of Americans. Medicaid is how America actually pays for long-term care, and H.R. 1 took a sledgehammer to it. These cuts don't eliminate costs, they shift them. When someone loses home care, they end up in an emergency room. When someone's personal care attendant disappears, a family member leaves the job to fill in the gap. The bill for H.R. 1 will be paid by families, and it already is, all for tax cuts for the wealthiest among us. Already, at least a dozen states, because of the cuts to from H.R. 1, have proposed and enacted cuts to home care, rate cuts for care workers, reduced services for people with disabilities and seniors. This fallout is not coming, it's here, and the impact cannot be overstated. My brother, Chris, describes the Medicaid that he receives this way. Medicaid is a lifeboat to people like me. It gives my life color, and every day it means freedom. We're here to protect that freedom. There are real solutions to address the affordability of care, including, of course, passage of Medicare for All, and also passage of Representative Dingell's Home and Community-Based Services Act, which would make home care a mandatory service in Medicaid and eliminate those waiting lists. We need to invest in the direct care workforce, and for Medicaid's 70 million enrollees, Congress should add a robust home care benefit, again, to match the public assumption that it already does. Finally, we must invest in the direct care workforce, raising wages and creating pathways to citizenship for immigrant care workers so that we can care for the people that we rely on to care for our families. If we affirm care as a national priority, we can lower costs, support families, and ensure people like my brother Chris can keep living with the freedom and dignity they deserve. I welcome the opportunity to work with the caucus, and I'm happy to answer any questions. Thank you.
Thank you so much, Ms. Jorwick. That was incredibly enlightening. We appreciate you being here. Our next and final witness is Bobby Laughlin. He's a 32-year-old resident of Baltimore, Maryland, who works in both the restaurant and HVAC industries, holding 2 jobs that do not provide health insurance. He purchases coverage through the state marketplace, giving him direct experience with the affordability challenges that are facing marketplace consumers. Since 2023, Bobby has been involved in healthcare advocacy in Maryland, first testifying before the Maryland General Assembly in support of the Maryland Young Adult Health Subsidy, which provided additional assistance to young adults purchasing health insurance plans. Mr. Laughlin, I will hand it over to you. Thank you.
Good afternoon, and thank you for inviting me to testify today about the healthcare affordability crisis facing millions of Americans. My name is Bobby Laughlin. I'm from Baltimore, Maryland. I work 2 jobs in the restaurant industry and in HVAC. Neither of my employers provide health insurance. Like millions of Americans, I rely on my state's health insurance marketplace to purchase coverage. At this time last year, I was able to obtain quality, affordable health insurance because of the Affordable Care Act premium tax credits. Those enhanced credits helped lower monthly premiums and made comprehensive coverage realistic for working people. They allowed people like me to choose plans that would actually be there when care was needed, rather than plans with deductibles so high that coverage only felt useful after a major medical emergency. As of the beginning of this year, those enhanced tax credits expired when Republicans refused to negotiate in good faith and instead chose to strip nearly 20 million Americans of access to health care that they relied on. For me, that meant my monthly premium increased from $70 to $460, a more than 6-fold increase. I simply did not know how I would afford it, and I was preparing to cancel my insurance. Fortunately, Governor Wes Moore and the Maryland General Assembly stepped in with a temporary state solution to help cover the gap left by the expiration of the enhanced credits. Because of that action, I've been able to keep my health insurance. Sadly, this has not been the case for most Americans affected by the non-renewal of the enhanced tax credits. Many Americans have been forced to choose between paying for health insurance and paying for rent, food, utilities, or other basic needs. Others have had no choice but to drop coverage or take on debt to keep it. Earlier this year, I suffered from a fall that fractured one of my vertebrae. With insurance, I was able to get the diagnostic imaging, physician's visits, and follow-up care I needed. Without insurance, that care would have cost me nearly $10,000. I cannot imagine facing that injury without coverage, and I know many Americans are forced into that position every day. When people delay care because they cannot afford it, treatable problems become emergencies, families suffer, and the healthcare system becomes more expensive for everyone. Marketplace consumers are not the only Americans facing uncertainty. People who rely on Medicaid are also confronting administrative requirements that may make it harder to maintain coverage. States will have to process more eligibility reviews and paperwork, increasing the risk that eligible people lose coverage because of delays, confusion, or administrative barriers rather than because they no longer qualify. The United States remains an outlier among developed nations in how many people struggle to obtain affordable health care. We can and must do better. Enhanced premium tax credits made coverage more affordable for millions of Americans and helped reduce the risk that a medical need would become a financial crisis. Congress should act urgently to reinstate them and to ensure that every American can get the health care they need without risking financial ruin. There's a health care affordability crisis in this country. I applaud this committee for recognizing that reality and for opening a dialogue about serious solutions, not only to this crisis in healthcare, to the crisis in healthcare affordability, but also to the broader challenge of making life in this country affordable. Thank you again for listening. I look forward to answering any questions you may have.
Thank you so much, Mr. Laughlin. We're now going to move on to questions from members. Members will speak in a first-come, first-served order, and we'll each have 4 minutes. We're first going to go to Congresswoman Dingell and then to Congresswoman Suzanne Bonamici.
Thank you. You're doing a great job. Ms. Jorek, in your testimony, you outlined the challenges you faced as a family caregiver in navigating our healthcare system, as well as the work of caring across generations. And the Care Can't Wait Coalition are doing to build a care economy that guarantees affordable care to all. What are the main factors driving the cost of caregiving for older adults and people with disabilities?
Thank you for the question, Representative Dingell. The main cost drivers are the fact that quite simply, there are not other places that cover this set of services. Employer-sponsored coverage does not cover long-term care. Medicare, outside of a very narrow home health benefit that is underutilized and underfunded, does not cover long-term care. And so the cost drivers are really clear. And in addition, as you mentioned in your remarks, Representative Dingell, the reality is that we know from our polling that 95% of disabled people and 90% of older adults per AARP want to be able to live and age in place, but that is not the system that has been created. We have been talking about quote-unquote rebalancing long-term care since the 1980s when home and community-based services were created, but that rebalancing has never actually happened, and therefore when it comes to federal and state money, the vast majority, not vast majority, but still a good chunk of it is going to facility-based care. The spending for long-term care does not match that 95%. If we saw that, then families would have what they need. We wouldn't have nearly 1 million people on waiting lists. And so those are some of the drivers. And the reality is that families are the ones that are filling in the gaps to their own retirement security that they can't have, their own finances where they're spending 26% on caregiving. I know I literally just left my mom, who's currently redoing a whole house for my grandparents that are both 93. My grandmother has Parkinson's, and they're some of the lucky ones that can do that.
I'm going to ask you another question about HR1 in a minute, but I want to build on that because I think people don't pay attention to who the families are doing the caregiving, which means not in the workforce, don't have health care, not building pensions, and using resources. I don't know if you want to comment on that at all, because I think a lot of people don't think about that.
Yeah, absolutely. For the family caregivers who are filling in the gap, the cost of that per AARP is $1.1 trillion that we're providing to the economy, but that comes at a great detriment to personal financial security. And the reality is that the woman that you talked about coming up to you at the grocery store, those are the phone calls and the emails and the conversations that I'm having all over the country. So many people who are in a caregiving role it's not until that's over that they then look around and see the kind of carnage that has happened to their own finances, their own well-being as well. All of that also has costs attached to it.
Thank you. You reference HR1 in your testimony too. How do the Medicaid cuts in HR1, and in particular cuts to home and community-based services, impact the affordability of caregiving?
Well, it can't be overstated, the impact of HR1 cuts. And we were very happy to see yesterday that 25 states sued the Trump administration on the overreach of the work requirements, but that's only accounts for about $400 billion of the cuts. We are seeing over 12 states have already cut rates. That means cutting wages for direct care workers. That means that wait lists are going to grow. And frankly, we're only just starting to feel it, and we haven't even hit the implementation dates. So the reality is that Medicaid was far from a perfect program to begin with, but the waiting lists for these quote-unquote optional services are major. And the other thing that it's going to do is push people into much more expensive institutional care. Because when all that you have left is either family caregivers who are going to do the care at the detriment of their own well-being, or people are going to be forced into nursing homes and institutions, because in 35 states there are still publicly funded institutions, then that means that that's going to be a huge cost to the system the system as a whole.
Thank you so much. That was her. Okay. Ms. Brown, same question for you. What are the main cost drivers for older adults and people with disabilities, and what policy solutions would make a difference in the lives of these individuals?
The main cost drivers is the broken system. We have a system that is, first of all, it's not a healthcare system. We have a system that treats symptoms but doesn't find cures. We have a system that is a racist system, an anti-woman system. We have a system that for so long our representatives didn't try to fix. And so here we are, and we have a sicker nation. We have older people, because we're able to live longer doesn't mean that we're living healthier. And we have people who are disabled and for whatever reason, whether that is, they were in an accident, they were born that way. We've had many wars that created a lot of disabled people. And so if you ask me, not being an expert on corporations and things of that nature, I would say that our system creates the costs, that our system that we created is the problem, and that it no longer works. And we need to do something drastically different to get it in line, so that we are giving health care, so that there is no profit in it, and that people are the drivers for health.
Thank you so much. We'll turn to Congresswoman Bonamici.
Well, thank you, Representative Ansari and Dingle, for hosting the hearing, and thank you to the panel of experts for laying out clear and tangible ways how we can reduce costs, including price negotiations, tackling corporate greed and corruption, and passing Medicare for all. And our healthcare system is broken. I'll note, I was listening to Mr. Laughlin's testimony. When employer-provided healthcare started, it was when a generation went to one job and stayed there for the rest of their lives until they retired. That's not the system we have now, and there are too many people who are slipping through the cracks. I also want to note the problem with private equity. We had a hearing in the Education Committee today about, a very bipartisan hearing about all the private equity investments in youth sports. That because they're putting profit over students. Well, they're also putting profit over patients in their healthcare investments, and that's something that we absolutely should tackle as well. Ms. Jorwick, thank you so much for talking about the value of caregivers. I've been through it with my mom, who started with dementia and then Alzheimer's, and all the different levels of care and how much it costs. It's incredibly challenging. My kids were grown at the time, but there's a bunch of people in the sandwich generation. We have to address this issue with care, definitely. But I also want to point out that Well, we're fighting to make healthcare more affordable. Our colleagues on the other side of the aisle in this administration are making things worse. One of the things that happened last week was that the Secretary of Education announced that she's moving OSERS, which is the Office of Special Education Rehabilitative Services, to the Department of Health and Human Services. And in light of the things that this president and secretary have said about people with disabilities, Mr. Ulrich, do you think that's a good idea?
I certainly do not. And as a former special education attorney, I can say it definitely is not. And it's moving people with disabilities backwards into a medical model under an administration that doesn't think that they should be in the community.
Right. I invite all of my colleagues, if you have not done so already, to sign on to my articles of impeachment, because closing down the Department of Education without Congress is against the law. Also, speaking of Secretary Kennedy, I also led a letter to the administration about their new website, moms.gov, which purports to be a supportive research for women, but in reality, it's pretty sinister because it deceives vulnerable people to say you can find a pregnancy center near you, and what it does, it directs them to a 24/7 hotline run by Heartbeat International, which is a radical anti-abortion network of more than 1,000 crisis pregnancy centers, which are not licensed medical clinics, and many intentionally delay access to time-sensitive prenatal care. They withhold FDA-approved birth control options. They push unscientific medical procedures, and public reporting reveals that Heartbeat International uses a centralized data platform to create a client risk tracker. So they're taking personal information from unsuspecting patients, all while completely exempt from HIPAA. So we're seeing the sort of deadly math of putting these anti-choice politics over women's lives. And I know this is about cost, but it definitely addresses the costs that women are paying. So I want to ask, also with the maternal mortality rate skyrocketing, especially with black moms, more than 3.3 times more likely to die as a result of a pregnancy or birth than white moms. So I want to ask Ms. Jorwick and Ms. Brown, when an official platform like moms.gov acts as a funnel for unlicensed, misleading facilities, what are the immediate public risks, and how do these deceptive delay tactics directly contribute to worsening maternal mortality crisis we're already seeing? So, Ms. Jorwick and Ms. Brown.
Yeah, I mean, ultimately that website is using taxpayer dollars on a pronatalist and anti-choice, anti-woman website, and it's littered with misinformation. And we know what moms want. What moms want is addressing affordability. Moms want, exactly. Moms want childcare. Moms want paid leave and affordable health care, not being pushed to pregnancy centers that are actually anti-abortion, and also unscientific nonsense, including some of the CDC guidance that is on there. It is a complete misuse of federal funds, and again, doesn't actually get to the heart of what parenting people want.
Brown, your thoughts?
I believe it's a control issue. I mean, they want women out of the workforce. They want women barefoot and pregnant, and this is an attempt to do that. It's all off the backs of women. I believe that we need to be able to make sure that people know what is out there, what's available, what they can do, where they can go, what is real versus what is moms.gov, right? They know we need to control AI that is putting out misinformation in a way that is really dangerous and completely confusing the issues for people. So you Google and you think you're getting accurate information, and you get...
I appreciate that. And the clock is flashing, but I just want to know what an economic issue it is if someone can't decide whether or when to have a child.
Right.
I yield back. Thank you.
Thank you so much. Next up, Congressman Chuy Garcia.
Thank you, Chair Ansari and Congresswoman Dingell, for convening this important shadow hearing, and thanks to all the stellar witnesses that have really spoken with clarity and offered solutions as well. Healthcare should be a basic human right and not a luxury reserved for those who can afford it. Yet every day, families in my district are forced to choose between filling a prescription, paying rent, or putting food on the table. while working people struggle to afford life-saving care, large corporations, as all of you have pointed out, continue posting record profits. Whether it's Big Pharma charging outrageous prices, PBMs inflating drug costs behind closed doors, or corporate hospital systems driving up prices through consolidation, our system is designed to maximize profits instead of keeping patients healthy. Many of the families I represent are immigrants or in mixed status households. I've heard from community health centers and local providers that families are delaying care because they're afraid of interacting with public institutions or worry that seeking care could have immigration consequences. I've also heard from school leaders and community organizations about the growing mental health impacts on children living in mixed status households. Mr. Spiro, from a healthcare cost perspective, what happens when families are forced to wait until illnesses become emergencies, and how do untreated mental health needs contribute to higher healthcare costs over time?
I think it's pretty clear, Congressman, that untreated illness leads to preventable hospitalizations, longer hospital stays, and even increased mortality. And we are stuck in a system that is a sick care system, and we need to reorient to invest more in prevention and public health to not only to improve health, but downstream lower healthcare costs. On mental health care, mental health care is physical health care. They are obviously related, and addressing one requires addressing the other. And we need to put mental health on an equal footing with primary health. And I think we need to look at mental health parity again and ensure that reimbursement rates for therapists and mental health providers are equal to primary care physicians. That's the only way that we're going to increase access to mental health care.
Thank you. Ms. Strowick, how does hospital consolidation affect not only prices, but whether communities have access to care at all?
Sure. So we know that since H.R. 1, over 1,000 hospitals have closed. That's also true when it comes to community health centers and other care facilities that are incredibly important. So what that means is that people are going to have to go further for care, or that family caregivers are going to have to fill in those needs for themselves when it comes to the longer term care. And when it comes to health care, what it actually means is that the vast majority of people, especially caregivers, are just going to continue to go without.
Thank you for that. The healthcare affordability crisis, of course, isn't inevitable. It's the result of policy choices, as all of you have pointed out, that have prioritized corporate profits over patients. We, Congress, have the tools to lower prescription drug prices, break up big medicine, crack down on anti-competitive practices, invest in preventative care, strengthen the care workforce, eliminate medical debt, and finally, enact Medicare for all to guarantee health care as a human right. Thank you all for your testimony. Look forward to our continued struggle for health justice.
Thank you so much. Thank you, Congressman. Next up, I will turn to Congresswoman Emily Randall.
Thank you, Chair Ansari and Representative Dingle, for putting this shadow hearing together. It's such an important topic, and healthcare access and affordability is my political why. I saw what Medicaid expansion in Washington State did in the 90s for my disabled sister Olivia. I saw that it took Medicare plus union pensions plus Medicaid to meet the needs of my grandparents as they faced the end of their life with dignity. And I saw what we were able to achieve in Washington State when we expanded Medicaid, developed a public option, and created the country's first public long-term care benefit while I was in the state legislature. But this week, as we celebrate the 1 year of Republicans' big ugly bill and the egregious cuts, approximately $1.15 trillion on federal health care spending over the next decade, I am scared. These cuts will result in the loss of health care coverage for over 15 million Americans, including some of the country's most vulnerable population, kids, pregnant women, disabled individuals, seniors, veterans, folks who both sides of the aisle claim to stand up for. Our own Medicaid expansion in Washington state is at risk because of the Medicaid cuts in the big ugly bill. And I hear from constituents back home who have to decide on whether to pay for antidepressants or buy groceries. And though we have enacted significant policy to control the prices of prescription drugs in our Washington, for insulin, for example, there are many folks on federal insurance plans that need to be regulated by Congress. Choosing between food and medicine is an inhumane struggle that nobody, especially elders, veterans, and Americans with disabilities in the richest country in the world should have to experience. We absolutely have to do better. Mr. Spiro, given that many hospital markets are already highly consolidated, including in my Washington, and you mentioned some of the policy suggestions to lower costs, what else should policymakers be focusing on to counter this consolidation, vertical integration, and private equity investments to lower costs without compromising access to care? And I want to caveat this or add on that I'm very mindful of the struggles that hospitals are facing because of the HR1 cuts, and the system was in trouble before HR1, so it's our job to think about how we rebuild it better.
Yeah, and I'll start by saying that I think antitrust enforcement is definitely part of the solution, especially on the health insurance side. We ought to be breaking up those big health insurance conglomerates that own doctors' offices, PBMs, and pharmacies. On the hospital side, it's difficult to break up hundreds of hospitals now that the consolidation has already occurred. And in that situation, when you have uncompetitive markets that are just not functioning, the solution is price regulation. And that's why we've proposed a cap on hospital prices and on hospital price inflation. We have to make sure that we're directly linking that reform to the consumers and making sure that they're benefiting from that reform. But I think that we've reached a breaking point where we need to take action. And if we don't get a hold of hospital costs, which are the main driver of healthcare costs, we're never going to solve this affordability problem.
Absolutely. And you talked a little bit about the other vertical integration pieces of PBM and insurance companies, private equity. I think it's clear that we need to tackle all of those things in order to find any cost controls in the system.
Yeah, and I think that the ideal solution, again, is to break up those big health insurance conglomerates. We support Senator Warren's bill with Senator Hawley, and we just recognize that that kind of unwinding will take probably several years and will be subject to numerous challenges, lawsuits. And so what we're saying is, in the meantime, there are solutions where we can make sure that those conglomerates are not using their subsidiaries to game the medical loss ratio, to rig the system in a way that they're able to increase the spending that they count as medical spending, and then turn around and increase profits and premiums.
Thank you. And Ms. Brown, I think we often are talking about costs and not the human beings that are care providers as we talk about the challenges facing the healthcare system. Can you briefly explain the connection between Medicaid funding and the ability for healthcare employers to recruit and retain nurses, nursing assistants, and other frontline workers?
Yeah, so if the hospitals don't get the money, they don't have the ability to hire more staff. We are currently in a shortage of healthcare workers. COVID decimated the healthcare workforce, and they have never recovered. And so We have in every level, not just nursing. It's housekeepers and CNAs and dietary workers. They are not there. And so you have a less quality care being given in facilities. If one nurse has to take care of 20 patients, 20 patients are not getting quality care. And so it is devastating the care system, and it is making caregivers sick. It is wearing on the caregivers themselves.
Thank you so much. Next, we will turn to Congresswoman Chantel Brown.
Thank you. I'd like to thank Congresswomen Ansari and Dingell for holding this critical shadow hearing today. This week marks 1 year since Republicans passed Trump's Big Ugly Law, a law that made the largest cuts to Medicaid in our nation's history, a law that ripped health care away from 17 million Americans, including over 300,000 Ohioans, a law that slashed food assistance from children, seniors, veterans, and made college more expensive for working families, all to hand massive tax cuts to the wealthiest Americans. 1 year later, working families are still paying more for groceries, more for housing, more for utilities, and more for prescription drugs. Meanwhile, the wealthiest Americans are cashing in. That's the Republican affordability agenda, a reverse Robin Hood. We need to not only reject Republicans' welfare for the wealthy agenda, but also offer the American people a better path to lowering costs. The Congressional Progressive Caucus is doing exactly that. If we're serious about affordability, we have to stop asking Americans to settle for a health care system where getting sick can mean going broke. That means protecting and strengthening Medicaid, not gutting it. It means expanding Medicare coverage and benefits until every person has access to comprehensive health care. It means giving workers the security of paid family and medical leave so they don't have to choose between a paycheck and caring for themselves or a loved one. It means raising wages, protecting the right to organize, and ensuring working people have the bargaining power to keep more of what they earn. And it means taking on one of the biggest drivers of health care costs in America, prescription drug prices. Democrats proved that progress is possible when we finally gave Medicare the power to renegotiate prescription drug prices back in 2022. We also capped Medicare Part D out-of-pocket costs at $2,000 a year and put protections in place against outrageous price hikes. Those reforms are already making a real difference for seniors. So, Mr. Weissman, do you believe we should look at extending these same type of protections to Americans who receive their health insurance through their employers? And beyond that, what additional steps should Congress take to ensure no one in America is forced to ration medication, skip treatments, or incur back-breaking medical debt simply because they got sick?
Yeah, thank you for the question. I mean, of course, the answer is yes. I think, as I was detailing in my testimony, Medicare negotiation was a good first step. It's very modest, but the principle is right. So if we cover all drugs, we start right away, and we establish that the standard is we don't pay more than other countries do. We can cut drug prices by more than half for everybody on Medicare and everybody off Medicare. And then to the last part of this, it was a historic move to create the out-of-pocket cap at $2,000, but it really should be zero because no one should be paying anything. If we take those measures to reduce drug prices, we will save overall the country $200 billion a year. Plenty of money to cover that out-of-pocket costs and a lot of the other priorities that are being discussed here today.
Thank you. And Ms. Brown, thank you for bringing the labor perspective to this conversation. Your testimony makes clear that when healthcare corporations keep wages low, understaff facilities, and fight workers who organize, it's not just workers who suffer, patients do too. Can you tell us why Congress should view investing in the healthcare workforce through living wages, union rights, safe staffing, and paid leave as an affordability strategy and not just a labor issue?
If you have a hospital that is staffed properly, people are getting better care, and so they're not there as long. If you have a nursing home where they have enough staffing to take care of the patients, because they're not just elderly. There's disabled people and young people who are undomiciled are now in the nursing homes. And so if we take care of the people who are ill, if we allow the people who are giving care to make a decent wage, to be in a union, if they choose to be in a union, if we control the greed, if we can control the greed and put the money where it's supposed to be and actually giving quality care, we will be able to control the affordability.
Well, thank you so much, and with that, I yield back.
Thank you. Next up, we will turn to Congresswoman Alma Adams.
Thank you. Thank you all very much. And let me, first of all, thank Task Force Chair Ansari and Congresswoman Dingle for hosting this critical hearing and for giving us all the opportunity to discuss the impact that the Republicans' massive Medicaid and Medicare cuts will have on Americans with our panelists today. Republicans claim that they're making a legislative effort to increase transparency and accountability in our healthcare system to lower costs. And yet we find that they're choosing to ignore the reality that these bills will do little in the face of the incoming tsunami that's going to hit our country. The $1 trillion in Medicaid and Medicare cuts passed in the one big ugly bill. And the new work requirements that are going to kick so many recipients off Medicaid, not because they're ineligible, but because the requirements are so unnecessarily complicated. And not only that, we can anticipate serious delays in Medicaid enrollment approvals due to the immense administrative burden placed on understaffed state and county workers that Ms. Brown just talked about. And in my home state of North Carolina, Medicaid eligibility determinations and enrollment are all done at the county level. And I can tell you, frankly, that most of these counties, especially our rural counties in North Carolina, do not have the infrastructure nor the staff capacity to take this on, especially when the administration refuses to give states the most basic tools that they need to succeed. The Centers for Medicaid and Medicare Services have only just released guidance for how states can maintain compliance with work requirements, giving states very little time to implement those changes. Ms. Jorwick, how do you believe that these complex and frequent documentation requirements for Medicaid will impact the enrollees with disabilities and chronic health conditions?
Yeah, I mean, people are terrified about the work requirements and having to choose between working part-time as much as they're able and losing their access to coverage. The way that the administration and CMS went beyond what congressional intent was and did things like connecting medical frailty to the ability to work is going to have a massive impact on disability employment, and it's going to mean that we know that the numbers are that people are going to lose, at least 5 million people will lose coverage just because of the work requirements. So the red tape and paperwork is astronomical.
Okay, thank you. Let me ask you about the impact of CMS's changes to qualifications for enrollees who are medically frail. Now, the eligibility is not based on just the diagnosis, but also verifying that this condition fully prevents an enrollee from working or doing community engagement. For disabled people who work but who don't meet the monthly 80-hour threshold, they could lose their health care coverage and home-based support services. So could you expand on how H.R. 1 threatens disability employment and disabled workers' access to home and community-based services?
Absolutely. Again, because of the overreach that the administration did with the interpretation and the interim final rule, it means that people with disabilities, including people like my brother, would have to say, I can't work in order to keep the care that I need. When what we should be doing is encouraging disabled people to be working, even if it's only 10 hours a week, to be doing volunteer volunteer hours to the best of their ability, but we also know that disabled people are working 40 hours a week just to live in the country because of all the complexities and barriers that we put up.
Now, the Congressional Budget Office estimated that around 10 million people will lose their Medicaid coverage by 2034. Mr. Laughlin, based on your own experiences with healthcare system, what do you think the long-term impact is going to be on those who don't receive health insurance through their place of employment and rely on Medicaid?
I think that people will suffer. I think that people will die. I think that people will, in my experience, when I broke my back, I think that I wouldn't be able to get treatment to know when I could work again or what I could safely do. So that was a pretty serious injury, and I could have hurt myself much more had I not gotten medical counsel. So I think you'll see that people will continue to have those jobs. People will always work those jobs, and they will always suffer unless we work to make sure that people like me can have access to insurance. Just continue to be a massive problem, and
Thank you very much, and thank you to all the panelists. Thank you very much.
Thank you so much. Next, we will go to Congresswoman Melanie Stansbury.
All right. Well, good afternoon, everyone. Thank you for being here. I'm going to ask all of you at the end for a lightning round of what would be your one big policy you would pass if you were in charge and votes weren't a hindrance. Like, what's the big policy ideas we should be thinking about? But I want to start by just sharing, I believe healthcare is a human right. This is a personal issue for me. I grew up in a low-income family in New Mexico with a single mom without health insurance. I grew up in a family that was saddled with medical debt. I grew up in a family where we didn't get care because we didn't know what would happen if you went to the hospital. And so for me, this is personal, and I know for millions of Americans out there it is. And I could not agree with you more, Ms. Brown. The system is broken. It is so terribly broken. I had my own run-in this weekend with a cold. I went to the ER after I was sent by the Capitol doctor and ended up with a $500 bill from going to the ER. I'm a U.S. Congresswoman, and I got charged $500 for going to the doctor. And it's, you think about low-income people going to the doctor and what that would do an emergency to your ability to even get gas to go to work tomorrow. And so the system is just so terribly broken. And I think what breaks my heart is to see how this president, this administration, and this Congress have intentionally broken it further. And the statistics we've seen even over the last week or two is that we have 3 million Americans who've lost their health insurance under the Affordable Care Act subsidies. We have more than 3.5 million Americans have lost food assistance over the last year. There's a ProPublica report that is saying that 770,000 of those people who lost food assistance were children. In the richest country on planet Earth, people cannot get health care and they cannot get food. A report I saw last week said that there are more hungry people and more people skipping meals right now in America under Donald Trump than during the pandemic at the height of the supply chain issues. I'm trying not to swear, but that is outrageous. That is outrageous. And so, for me, when I look at what this administration and this Congress have done over the last year, it's cruel, it's corrupt, and they're taking American taxpayer dollars and using it for vanity projects, wasting millions of dollars on the pool across town, on, building new ballrooms, on bombs overseas for a war that we voted against. And our people in this country can't even get basic health care and food. And to me, that is like a violation of the public trust. And in places like New Mexico, we've stepped up. We're doing everything we can. When they passed the big ugly bill, New Mexico said, fine, we'll cover health insurance and we'll cover food assistance. We pass free child care in New Mexico. We have free college in New Mexico. We're doing everything we can, but it's going to break the bank. We can't do it forever at this rate, especially with this Congress and this administration out of control. And so that's why I believe, and I think this hearing is so important, as we look forward to 2027 and 2029 when we take back the House and then take back the White House, we got to go big or go home, because the American people are hurting right now. And that's why I really would love to hear from you is what are the big things we need to do to fix this broken system? And if we could just go down the line.
I would say Medicare for all, would be huge if it were up to me. That would just solve so many problems, and it would put us on par with really the rest of the developed world, which would be great.
Yeah, I think Medicare for All does include long-term care, so that's important. I think it's a home care benefit in Medicare, obviously, and then also making sure that home care is a mandatory benefit in Medicaid, and importantly, all undergirded by support for the direct care workforce.
100% will sing from the same hymnal. It's exactly right. We have to undo the harms of Trump, but that is nowhere near enough. I think the hearing is right. We have a system of profits over patients. Medicare for all is the way to have patients over profits. The issue that I was talking about, drug pricing, would be dealt with in that context, but Medicare for all is the way to deal with vast parts of this and really focus on health instead of corporations making money.
Well, ditto Medicare for all and end Citizens United.
I think in terms of immediate relief, we need to regulate hospital prices because, as I said in my testimony, that's what increases premiums, deductibles, out-of-pocket costs. It lowers wages, and it increases unemployment and drives income inequality. So in many ways, hospital costs are the root cause of all of these problems, and we need to address it.
Thank you all so much. I agree wholeheartedly. And I also want to say thank you for bringing the labor aspect into it as well as the mental health and behavioral health. New Mexico just found out that the DEA dumped fentanyl into our communities, and we have a behavioral health crisis in New Mexico, and also elder care. So many of our seniors are really in crisis right now. So thank you.
Thank you so much. We will turn to Congresswoman Adelita Grijalva.
Thank you. Thank you all for being here. I know how difficult it is to navigate coming here from all over for a short period of time, so I know that I appreciate it and all of us do, and I also want to thank Representatives Ansari and Dingell for organizing us together to have this really critical conversation. I believe healthcare is a human right, yet working families continue to be crushed by corporate greed, bloated insurance profits, and skyrocketing out-of-control, out-of-pocket expenses. Today's shadow hearings highlights the urgent need to put patients first, rein in pharmaceutical prices, and ensure universal, comprehensive coverage for all Americans. Republicans pretend to be anti-bureaucracy, yet they pass laws that are designed to bury people in red tape and prevent them from getting Medicaid coverage. These bureaucratic cuts don't save money in the long run. Despite what they say, in the long run, it actually is harming so many people. First, they harm patients, and they put hospitals, nursing homes, maternity wards, critical providers across the state at risk of closing their doors. They create healthcare deserts, which we have the threat of here in Arizona in my district, and clinics have closed or are on the brink of closure. Jobs will be lost while chronic diseases and illnesses worsen, and in the end, no one is better off. So my first question would be to Nicole. Since Medicaid is the only public program that covers home care, what do middle-class older adults do when they need care?
For older adults in the middle class, when they find that they need care, they have really limited options, and that includes my 3 grandparents. Grandparents who want to pass homes and retirements down to their grandchildren instead have to sell their homes, spend down their savings that they worked their entire lives for to impoverish themselves to qualify for Medicaid. And even once they've done so, they still could end up on a waiting list that currently sits at over 600,000 people. And that, I should say, is only for those who know that there's a list to be on. Right. So right now, 8 in 10 older adults would be unable to cover long-term supports and services. So frankly, what they do is go without and rely on us family caregivers.
Yeah. I really worry in my community. We have a lot of rural clinics that are at risk of closure, and so instead of being able to get chemotherapy care 20 minutes from your house, you're going to drive to Tucson, which is 2 hours. And some people just don't have the capacity or ability to be able to do that. And so I worry about that all the time. And Mr. Laughlin, I want to ask your testimony. You state that you were facing a health insurance monthly premium increase from $70 to $460. I appreciate you sharing your story and putting a face face to the issue. Many of my constituents in Arizona have faced a similar issue with health care insurance premiums spiking by an average of 29%. Would you like to share any more about how difficult of a situation this put you in, and were you considering going uninsured, and what would have happened if you did that?
Yeah, of course. I moved home with my parents. I couldn't afford to live by myself anymore. And so, yeah, it hasn't been great. And if I didn't have insurance, it would be a massive problem. You know, I'd never broken a bone before, and then randomly I got into an accident in which I fell and I broke my back, and if I didn't have insurance, it would have been a massive problem. So I'm very thankful for the programs that we have that will allow me to keep it. But it's just a massive problem.
It really is, yeah. And thank you. And Topher, I appreciate you bringing up the issue of prior authorizations. I'm deeply concerned with the growing utilization of these to deny care, go against doctors and even oncologists. I had a whole room full of doctors come to my office about AI and pre-authorizations. And so can you talk about how this landscape could evolve with the use of AI, and what will that mean to patients being able to access care on their doctor's orders?
There should absolutely be a ban on making these decisions without human review. And as we said in our proposal, it needs to be human review by actual qualified clinicians, not by insurance company bureaucrats. Mm-hmm. And importantly, in doing that review, not using arbitrary made-up rules which vary insurer by insurer, but using a single set of evidence-based clinical guidelines that physician organizations have already developed and published on their websites. So it's already out there. It's not the government doing it. But we need to ground these decisions in the evidence. And we need to limit these reviews to only the most costly and widely overused services. All routine, essential emergency care should not be subject to prior authorization.
I agree. Thank you all so much. I yield back.
Thank you so much. Next, we will turn to Congresswoman Maxine Dexter.
Thank you so much, and thank you to Congresswoman Ansari and Dingell for convening us, and thank each of you for coming. It's truly an honor to be able to discuss this with you today. Many people know, but I'm a doctor, I'm a mom. I ran for Congress because the things that I could treat in my exam rooms weren't the things people really needed addressed. Housing insecurity, addiction services, the fact that they can't pay their bills with the low-income jobs that they are sometimes working 60, 70 hours doing. So I came here to make an impact, and I agree with, I think, what each and every one of you said, that we need Medicare for all. And I would argue that when we say that, most of us believe that we want universal, affordable, accessible, high-quality health care. And frankly, as a practicing physician, I can tell you that Medicare right now, as it's working, is not that. And so I challenge us to actually think differently about the solutions, because what I believe is that every physician should be able to have autonomy with their patient to use their professional best judgment and have access to the treatments and the services that their patients need. Medicare also doesn't treat vision, it doesn't cover vision, dental, hearing, home care, full pharmaceutical costs. That is not sufficient. So I know that we have enormous amounts of work to do, but I don't think just expanding Medicare is going to actually get us to what I think we all are saying when we advocate for Medicare for all. I want to pivot to something that is also incredibly important, that's biomedical research, and that the United States spends tens of billions of dollars on it every year, playing a role in bringing most of the prescription drugs to market. But we do not use our leverage to ensure that patients get a good deal on those drugs when they actually are out on the market. We must build a system our patients deserve, and that starts with incentivizing the outcomes that we want to see. So, Mr. Weissman, I think we agree that the federal government has utterly failed to ensure that patients, not shareholders, get the benefit of our massive investments in research and development. As Democrats, we push for transformative change in our healthcare system, as we just discussed. Can you speak to the concrete steps Congress should take to ensure that public dollars that are driving public benefit are actually rewarded to patients and not to shareholders on prescription drugs?
Yeah, well, before the congressional part, there's things that the executive can do using existing authority. So where government money led directly to the creation of a patented drug, the government has the authority to so-called march in and make demand that a reasonable price be made available. It's never done that. It's aggressively refused to do that under both administrations, including when we have directly petitioned them repeatedly to do so. That's the model, but where the hook should be less. So as you point out, government funding is responsible in some way for the creation of every single new drug that's come on the market in the last 30 years, according to reviews. There should be a condition built in. If you're taking the money, we expect you to have reasonable pricing. Right. And it's not that hard to actually create markers of what reasonable pricing is, but we have to just commit conceptually to doing it.
Thank you. And I would just assert that we are subsidizing the development on the front side with research and development, then on the back side paying higher costs than any other nation in the world. In the shorter term, can you talk about how patients would benefit from reining in patent abuses, whether it's patent thickets, product hopping, or pay-for-delay schemes that Big Pharma employs to price gouge patients and prevent lower-cost alternatives from coming to the market?
Yeah, the short version is that all of these elaborate tricks with the patent system enable to extend the patent monopoly. So we know that when generic competition is introduced and it becomes robust, prices fall 80 to 90%. If you can delay that for a year, 2 years, 5 years, you're holding off the time when the American consumers and patients finally get the benefit of those lower prices.
Thank you. In addition to proactively bringing prices down, we also must address the medical debt that's already weighing on families and the protections from that debt impacting their credit scores, bankruptcy, those sorts of things has been removed. Finally, for Mr. Weissman and anyone else who wants to weigh in, what reforms are needed and what would they mean for people already carrying that burden?
I think in terms of medical debt, we should really cancel it. I mean, they're unjustly accrued debts, really. These are not debts, even if you think about student debt. Students are getting something for it, and they're making a decision and an investment, and there's a return on it. Not that people should be saddled with student debt. But you have medical debt because you were sick, and then we punish you again by saying you couldn't afford it. We're going to throw that on top of you, make you pay it endlessly, and drive half of all bankruptcies because of medical debt.
Yeah, thank you. And I say I ran out of time, but thank you very much. I appreciate it.
Thank you so much. I'm just going to turn to myself for a couple of questions, and then I'll turn to our final colleagues who are here for the day. Mr. Weissman, my questions are for you. The United States pays prices that are 3 to 4 times what other countries pay for the exact same brand name drugs. Why is that?
Because we confer patent monopolies and then let the drug companies charge whatever they want to do, unlike every other rich country in the world.
And prescription drug corporations and their lobbyists like to argue with us that if we do anything to lower prices, we will be harming innovation. Should we believe them, or is there more to the story?
We should not believe them. There is more to the story. As we were just discussing, actually the floor of biomedical R&D is provided by the federal government. So that's the starting point. They do important work on top, but it's mostly late-stage stuff where the most difficult stuff has already been funded by the government. The amounts they charge have zero correlation with their R&D costs. There was a time when they used to say, oh, we have high prices because we have to pay for R&D. But the prices now are so high, they don't even pretend anymore. They just say, we're charging what we can, or it's worth it because we're saving a life, but we charge whatever we can. And then they only on the back end say, if we say lower prices, oh yeah, innovation. But there is zero correlation between the prices they charge and R&D expenditures in this country.
And how do these abuses by pharmaceutical company monopolies increase our prices and ultimately hurt patients in America?
Monopolists do what monopolists do. They charge the most they can, whatever the market can bear. That's bad enough when it's a discretionary product, but people don't take medicines for fun. They take it because it's life-saving or important treatments. And therefore, they're also willing to pay whatever they can, possibly. So the monopolists charge the most, and people either pay more than they really can afford, or they don't. So we know that 4 in 10 people are rationing the drugs that they are prescribed and otherwise need. That's a system that's working great for the profit-maximizing big pharma companies, and it's a disaster for all Americans.
And how do you think Medicare for All would serve to change the system and improve lives for Americans?
Well, to Representative Dexter's point, I think if we have Medicare for All, we would do things that are not just take the current system and take it down to age 0. One thing we would do is use the negotiating power that Medicare has, already is the biggest buyer in the world. If it covered all Americans, it would be by far the biggest buyer in the world. We would use that negotiating authority to lower price. And as I said, the standard for how to do that is pretty straightforward, building on what's currently in Medicare negotiation. And the basic standard is really simple. We should not pay more than other rich countries do. Just that simple standard will save us $200 billion every year.
Thank you so much. Next, I will turn to Congressman Paul Tonko.
Thank you so much, Representative Ansari, for your work and organizing us here, and also to Representative Dingell. And thank you to the panelists. In the United States, an estimated 3 to 4% of older adults skip doses, delay filling prescriptions, or simply do not take their medications as prescribed because of costs. For millions of seniors on fixed incomes, higher prescription drug costs can mean choosing between filling life-saving medications and keeping food on the table. The Medicare Low-Income Subsidy, also known as the Extra Help Program, helps ensure that those choices don't have to be made. It lowers out-of-pocket prescription drug costs by helping seniors pay for premiums, deductibles, and co-payments. Approximately 13 million Americans rely on that benefit, including more than 1 million beneficiaries in my home state of New York. So, Mr. Weissman, I'm worried that recent policy changes under H.R. 1 are making it harder for seniors to access these benefits. H.R. 1 delays efforts to streamline and simplify automatic enrollment of extra help recipients into the Medicare Savings Program, which helps cover basic Medicare out-of-pocket costs. What is the real-world impact on seniors when access to these benefits becomes harder to navigate?
It's unconscionable, and it's by design, as all of the excessive paperwork in the H.R. 1 reconciliation bill is designed to deny people access to care. So if people can't fill out the forms, can't get enrolled in the system automatically, they're not going to get the benefits. This is a really good program to make sure that very low-income seniors are able to get the medicines they need, and you're basically saying, too bad, we're not going to let you get it.
Absolutely appreciate that. And I introduced the Advancing Enrollment and Reducing Drug Costs Act to expand seniors' access to life-saving prescription drugs by automatically enrolling eligible Medicaid beneficiaries into the Extra Help Program. Looking ahead, what more can Congress and Democrats particularly do to cut through the red tape and ensure that seniors have access to lower prescription drug costs?
Well, your approach is exactly right, and everything that just makes it automatic and creates benefits as a matter of right with price controls built in, because it's systematic, is the way to go. So we should eliminate the out-of-pocket expense for everybody in Medicare. That would solve the problem of out-of-pocket expenses, because for people in Medicare, there wouldn't be any. It would be automatic, exactly as you're proposing. And again, we can pay for doing these things by, in the case of drugs, lowering drug costs by $200 billion a year for the country. And as we've discussed in the panel, there are many things we can do in the healthcare system to save money. And I think if we focus on the reason that healthcare is so expensive, which is just not that healthcare is so expensive, it's because corporations charge us too much, then it directs us to the solutions that can pay for the things that we really need.
I know that in talking to a number of seniors in my district, many of them will cut a tablet in half and just go that way because they cannot afford to fill their total prescription. And it just seems like a wasted bit of investment rather than giving them what they truly need and allowing them the dignity of having that full prescription filled so that they can go forward with that quality of life. So a lot of things we need to do, and I've been talking to a number of people talking about emphasizing the wellness and prevention elements of healthcare rather than just responding to sickness and immediate needs. So with that, let me thank you all for being a voice today of reason and for bringing attention to what is a very important issue that we're all wrestling with here. And it's good to have medical doctors on the team that can advise us too. So thank you. Thank you. I yield back.
Thank you so much, Congressman. And finally, we will turn to Congresswoman Mary Gay Scanlon.
Thank you, Chair Ansari and Rep. Dingell for organizing this hearing. Across the country, healthcare affordability is not an abstract policy debate. It's a daily reality, forcing families in my district and everywhere across the country between choosing to get the care, the medication they need, and paying for other basic necessities like food, rent, or childcare. And in my own district, that crisis has been compounded. The largest healthcare system in my district was run into the ground and eventually bankrupted by a private equity firm, leaving a massive gap in access to care for tens of thousands of my constituents. Critical community health centers are fighting to keep their doors open, while neighboring hospitals and primary care providers are stretched to the breaking point, trying to absorb the displaced patients. I've had seniors with chronic health issues tell me they're choosing to drive across state lines for emergency care because it's faster than waiting in the closest emergency room. Expectant mothers are giving birth in ambulances because they've had trouble accessing prenatal care and then getting to the hospital in time. And people are losing their lives because the care simply isn't there when they need it. Crozier Health collapsed after years of asset stripping, corporate greed, debt loading, and mismanagement. It's maybe the inevitable result of a healthcare system that allows private equity firms and corporations to treat hospitals like assets rather than basic care for our community. And so we've seen over 20 years these private equity firms dramatically expanding their footprint in hospitals and nursing facilities. We did follow some of the lead of our colleague from Oregon in introducing the Take Back Our Hospitals Act, which would prevent private equity firms from owning hospitals or skilled nursing facilities. Hospitals are essential public infrastructure, not hedge fund investments, or they shouldn't be. So if we're serious about making healthcare more affordable, we have to stop allowing corporate profit to come at the expense of patients' access to care. So, Mr. Spiro, private equity firms often argue they're making hospitals, nursing homes, other practices more efficient and providing a lifeline for struggling physician practices that might otherwise close. Can you explain why this model ends up driving higher healthcare costs and leaving patients with fewer options for care?
Thank you for the question. I think the evidence shows that what happens is when private equity buys up a hospital, they then slash nursing staff, as you were saying before. That results in lower quality of care, and the research, I think, almost universally shows that leads to bad outcomes. And as we've been discussing, when that happens, you end up having increased healthcare costs down the line. So I totally agree that we should prohibit hospitals from being owned by private equity.
Thank you. Ms. Jorwick, I was struck in your testimony, you have a section that talks about H.R. 1's cuts don't save money. They shift costs to families, emergency rooms, and nursing facilities. Obviously, our colleagues are celebrating the passage a year ago this week of H.R. 1, their big ugly bill. In fact, they had hoped to put a bill on the floor to give themselves a pat on the back. I don't know why Congress needs to pass legislation saying well done, especially when it clearly has been a problem. Can you talk a little bit about what the impact of H.R. 1 has been on health care?
Yeah, well, the impact on healthcare broadly, we have hospitals, community health centers closing, obviously, as you're highlighting. And when it comes to access to home care, which 95% of disabled people and 90% of older people want, it's going to make that further out of reach. We already had waiting lists. Medicaid was far from a perfect program before they took a complete decimation to it historically. And what that means is that the optional, quote unquote, optional services like home and community-based services that allows older people to age in place, that allow disabled people to work, will be almost impossible to get. And what that is going to mean is cost shifts to families, and it's going to mean cost shifts to other, because people aren't going to be getting the care that they need in a shorter term. That means that they're going to come into care sicker and needing more, and they're going to be forced into facilities that cost families more and also cost the federal government and states more.
Yeah, it's just very frustrating to see the misguided cuts, the, penny wise and pound foolish kind of things that we're seeing. I mean, including the fact that this big ugly bill cut SNAP benefits. I mean, we know from testimony we took last year that many workers in care facilities are paid so poorly that they have to rely upon public benefits. So it's a really perverse form of corporate welfare that they're able to pay such low wages that folks need to rely on public benefits. Thank you all for all of your testimony. We've been following remotely as I bop between hearings, but we really appreciate it.
Thank you so much. And as we wrap up, I just want to again thank each and every one of our witnesses for bringing your expertise, your personal stories, and your, in some cases, decades of work to the table here. And thank you to the CPC members who joined us this afternoon. This is part of the caucus's broader work to be ready for when we take back the majority, to have a bold affordability agenda that we can build broad public support for and actually pass and govern. And I think we heard from you very clearly that, and what we've heard from other shadow hearings that we've done, town halls across the country that we've done, it's time to be bold. The system is deeply broken in healthcare and so many other areas, and it would be the biggest mistake that we could possibly make to have a majority and to not be ready to go and pass policies that will benefit Americans and show that we can really deliver. So thank you for your work. Our work continues, and we look forward to partnering with you in the weeks and months ahead, and we really appreciate it. Thank you so much.
Thank you.